Thank you all for being here tonight. And I really want to thank Robert for inviting me. I got this email kind of out of the blue a couple of months ago saying, hey, you don't know me, want to come to Bakersfield? How can you say no to that? So here we are. I'm an HIV and infectious disease specialist. I grew up in New York, and I did my training in Boston. And like a lot of people who are from the Northeast, we have a very Northeast-centric view of the world. Like, you know, there's sort of the Northeast, and then there's like Hawaii. So if you had ever told me I was going to move to LA, I would have said you're nuts. But in 2006, I moved to LA, and with an interest in prevention, although I had come to it with a background from HIV care and treatment, it was really fascinating to me that you use some of these same medications that we use to treat people who are HIV infected, but in people who are negative. And as Eric was talking about, there's this strategy called PrEP, this post-exposure prophylaxis stuff, right? That many of you probably know about. If you've worked in a healthcare facility, you know that if you get a needle stick, or a splash of blood, and you're not sure if the person has HIV or not, or maybe you know they do, if you take HIV treatment medications as quickly as possible after that needle stick or splash, you can reduce the chance of you getting HIV by about 80%. You have to take that cocktail of medications for 28 days for it to work. And if you believe me, and I hope you will, that the most important parameter in PrEP working is the time that you were exposed to the time you got the medication into the body, so how quickly you got it in. And we actually think that it works best if it's taken within the first 8 hours of that exposure. Most guidelines say you should consider getting it out to 72 hours after the exposure, but as quickly as possible. If you believe me that that's the most important parameter, how could we possibly make that time from the exposure to the dose as short as possible? Well, the answer, if you sort of think about that riddle for a second, is, well, if the medication's in your system already when the exposure happens, then the time from the exposure to the dose is 0, right? Because it's already on board. So it was from that notion and the observation that PrEP works best the sooner it's given after the exposure that PrEP, pre-exposure prophylaxis, was born. Now, a lot of people think that's crazy talk. You're going to give HIV uninfected people medications that have side effects that cost a lot and that you have to take regularly for a long period of time to people who are negative. Well, on what planet does that make sense? And at first blush, that might seem sort of crazy. But let's think about it for a second. If you were to travel to Africa and you were afraid of getting malaria, before you went, you would start taking pills to prevent malaria. You would take it every day while you were there, and then for some period of time after you left that area, not because you were planning to get malaria, but in case you got exposed to it to prevent you from getting it, right? Same idea. Why do women take a daily birth control pill if they don't want to get pregnant? Not necessarily because they're planning to have sex on that given day, but if they do, and they don't want to get pregnant, they want to be protected. How is this different? Well, we can talk about that, but conceptually it's the same thing. Now let's think about one category that we didn't talk about of ways you can get HIV is a woman who's positive who gets pregnant, right? Mother-to-child transmission. The rate of an HIV positive mother infecting her baby, this is everybody in this country, about 25%. Worldwide it's about 40%. But let's say for the sake of argument 25%. But if the HIV-infected woman who's pregnant is on treatment, and you give an intravenous regimen during labor and delivery, and you treat the baby for 6 weeks after they're born, you can reduce that to less than 1% of those babies who are infected. So if you believe me that that's true, and I promise it is, and that works, isn't giving that medicine for 6 weeks to the baby really post-exposure prophylaxis? Because the baby was exposed, they're not infected, they're negative. We do this. We do this all the time. So why is it so crazy to think about this pre-exposure prophylaxis? I don't think It is. But in 2005, 6, when some of these studies that I'm going to tell you about were starting, a lot of people said, this is crazy talk, it'll never work. And if it does work, it's going to breed resistant virus. And even if it doesn't breed resistant virus, it's going to make people go out and have all kinds of unprotected sex with everybody in the world. And it's going to be a complete nightmare, because then STDs and HIV are going to be transmitted everywhere. This is what was said. Hold those thoughts. We're going to come back to each one of those points. Fast forward, 2010. It was around Thanksgiving of 2010. These results were published in the New England Journal of Medicine. And this kind of turned the world on its ear. Many of you have heard about this study. It's called the PrEP study. And the PrEP study, that actually is the name, it's the abbreviation of the study in Spanish. It's like Iniciativa Pre-Exposure Prophylaxis, something like that. But so that it was overwhelmingly in South America, but there were sites here in the United States as well. They took 2,500 men who have sex with other men and transgender women who were HIV negative, and they randomized them to either get this medicine, Truvada, and many of you know Truvada as part of the cocktail that we use to treat people who are HIV infected already. It's not enough to treat someone who's HIV positive by itself, right? We need at least one additional drug to add to Truvada for it to be a complete cocktail to treat HIV. And it works against this enzyme that Eric talked about, reverse transcriptase. So the way I like to think about HIV is, if viruses aren't alive, so you can't kill them, they're little robots. And that's even more scary to me. Clowns and robots scare me. I know, that's therapy for me. But anyway, so the virus is a robot, and it injects its genetic material, its RNA, as Eric said, into the cell. And then this reverse transcriptase is the first enzyme that has to work on that RNA. And what Truvada does, it's a monkey wrench that gets thrown into the gears of the robot and stops those gears from going and stops the virus from replicating itself. That's the mechanism by which Truvada works. So fantastic. So they either got Truvada or they got a placebo pill that looked, smelled, and tasted just like Truvada. You couldn't tell if you were getting the Truvada or this fake sugar pill that didn't have any real active medication in it. And people were told to take it every day, and they were tested for HIV once a month, Eric's favorite time frame. And they were tested for STDs every 3 to 6 months, and more often if they had any symptoms. And they all got condoms and counseling about how to use condoms, and recommendations that they continue to use condoms all the time, because number one, 50% chance you were getting a sugar pill that wasn't going to do anything. And number two, nobody's proven that this works, right? So even if it might work, we don't know yet. So you have to protect yourself like crazy. So keep using condoms all the time. That's what everybody was counseled in this study. At the end of 1 year, the people who got the real Truvada as opposed to the sugar pill were 44% less likely to end up acquiring HIV. Now, I don't know if to you that seems like a high number or a low number, a good number or a bad number. I'll tell you, I was disappointed. When I heard that number, I thought, you're kidding me. You're going to want me to take a pill every day that has costs associated with it, that needs lab tests, that has side effects, that only works 44%? Forget it. This is not a conversation I'm interested in. But it turns out that people like to say, well, what are the comparisons, right? Well, what are some other reference points for HIV prevention for some other methods that Eric was talking about, right? So condoms for men who have sex with other men are somewhere in the 70 to 90% efficacy range. Now, again, a lot of people like to toss around the number 90 to 95%. A study by Dawn Smith that was presented at the big HIV research conference last year kind of turned that on its ear a little bit and said maybe condoms aren't quite as effective as we thought they were, and came up with this number of 70%. But it's still, those are pretty good numbers, right? And 44% compared with condoms, 70 to 90%. This, again, is that a conversation? But those are apples and oranges. Because these numbers, the 70 to 90%, are when condoms are used all the time, every time, exactly as they're supposed to be. These are people who reported always using condoms and were able to explain that they knew how to do it and endorsed doing it all the time. Okay, this 44% number is not that. That is not the protection that you get from taking the Truvada pill every day as prescribed. That is the average protection that was seen over all 2,500 people who were in this study. And I will tell you that less than 1/2 of the pills prescribed to people in this study were ingested by anybody. Now, what this means to me is something that you all know already. If you don't take a medication, it doesn't work. That's not a surprise, right? You don't take your blood pressure medicine, it's not going to control your blood pressure. You don't take birth control, likely you're going to get pregnant. You don't take this, you can't work. Plain and simple. So, what did they do? This is like, there's this guy at University of California, San Francisco, named Al Liu. He works for the Department of Public Health there. He's super smart. And he did this really interesting study. He took 21 HIV uninfected people. He split them into 3 groups, 7 in each group. First group, he admitted them to the hospital for a while, and he gave them Truvada 7 days a week. He watched them take it, directly observed therapy. And he measured the drug levels in the blood, knowing that they took it 7 days a week. So he knew the drug levels. Second group of people, he admitted them to the hospital and watched them take Truvada 4 of the 7 days a week. Again, measured the drug levels. Third group, same thing, except he gave them Truvada only 2 of the days of the week. Again, measured the drug levels. Okay? So he knew what drug levels you would expect to get with those different dosing patterns. Fine, so what? He went back to the PrEP data set and looked at the people who had each of those drug level ranges and tried to figure out what this protection number was for each of those drug levels. And it turns out that from that he was able to model, this is a mathematical model, from the data from the PrEP study, that if you took it 7 days a week and got drug levels that you should get from 7 days a week, you would be 99% protected. What? 4 days a week, 96% protected. 2 days a week, 76% protected. Now we have a conversation. This is not a clinical trial result. This is an estimate of the potential protection you could get if you could actually get someone to take it 7 days a week. Now what's clear from this study, if you imagine these numbers as contributing to that average, how often were the people in that study on average taking that drug? Not so often. But if you could get someone to take the drug 7 days a week, that's pretty impressive. Okay? So I think that's some of the most interesting data that's been presented. So one of the most important questions that people get is, if you believe me that that's true, that that's the potential, well, how much is enough? How many doses can you miss and still be protected? How forgiving is this dosing? And it's very important to know that all the information we have about this is only in MSM, men who have sex with other men, and transgender women. We do not know the answer to this question for heterosexual women, and it's not clear that we know the answer for heterosexual men either. We'll come back to that.